Okay, ask questions. Any questions for me?
So one of the questions was the cues
verbal
for,
cue.
yeah.
Oh, stop and stare, I believe, is sympathetic. How can you differentiate? Did you guys see that question?
Yes.
Okay, and then how can you differentiate between an upslip and an anterior posterior rotation? Okay, so an upslip, right? Let's say this is my upslip slide. So an upslip could be an upslip or it could be a posterior rotation, but it can't be an anterior because an anterior rotation is going to look longer. So I don't differentiate between those two. So I will usually treat it as though it's an upslip, because sometimes if you do that grade 5 mobilization, you'll correct that upslip anyhow, or the posterior rotation anyhow. So I always treat upslip. Sometimes it corrects a posterior, sometimes it doesn't, and that's okay. Then you do the MET. There's because patients can't distract their own leg on their own. I've seen some things where they like take a towel and tie it to like a leg of a table and try and pull. I don't do that. I've kind of had a patient teach me that you can do your own grade 5 mobilization, and I call it a donkey kick. The patient stands up and kicks their leg out really hard to the side 3 times, lays down real quick, ball squeeze, and that corrects it. Anterior is anterior. There's nothing that could be anterior because it's longer. It appears longer. Did that answer your question?
So basically for the exam, we need to be able to identify like how to diagnose it and then like how to treat it.
For SI or for pelvic floor?
For pelvic floor.
Yeah, for the most part. Explain to me what this exam is for you guys. Do you have like a comprehensive exam or do you get an exam specifically based off of this course?
Let me actually explain it. The rest of the material is almost all covered. This exam has 10 pelvic floor questions plus some questions that are coming from the material before, but mostly it is from pelvic floor. But the grade is 10 out of 100. I mean, it's still very important, but it's mostly pelvic floor.
There's only 10 questions, correct?
From pelvic floor, but there's some other questions from other topics.
Got it. So I'm only submitting 10 questions. So it's not like.
Yeah.
Yeah. Okay. Someone just asked that. Sure. Oh yeah. Kegel verbal cues. So I use different ones based on the patient, and sometimes it's easier when you have your finger inserted, so they have something to get a little feedback on. One of the cues I use is, okay, you feel my finger, grab my finger and pull it up inside of you. Sometimes women don't get that at all, and I'll say pretend like you're holding gas in. Because if they do a rectal, like a Kegel rectally, they're still going to get some anterior portions of those fibers turning on, and that cues them a little bit better. I tend to not do pelvic tilts or anything like that. That doesn't inherently make those muscles come on. Okay, so for the diastasis, I would use those assessments and use them as interventions for restrictions found. So yes, I do core strengthening. I only strengthen TA, right? So if the diastasis is an opening of that linea alba at some point, and I do a rectus, it's just a rectus contraction. It's just going to open up more and more. So I won't give them a rectus contraction until they can give me a phenomenal TA contraction as a co-contraction so they don't over separate. I will use some of that myofascial release to see if I can approximate it a little bit more, to see if fascial tightness is part of the reason why the diastasis is staying. Doesn't always work, so sometimes it's not the actual reason, but I always try it just in case. Any other questions? You want to hear crazy stories? You guys tell me what you want.
I just want to explain that the final would be between 15 and 20 questions total. So you will get 10 pelvic floor questions and 5 to 10 questions from the beginning.
Yes, fascial restrictions absolutely can cause pelvic dysfunction. So that's why I tend to, if I find pelvic floor tightness and I find fascial restrictions, I will start from the outside layers and work my way towards internal tissues. I never start internally, because if you don't release the top layers, the bottom layer is not going to go. For Kegels, I've heard the phrase, act like you're trying to hold your pee in. Yeah, sometimes that cue works. I tend to avoid it because sometimes people try and sit on the toilet and stop their urine flow, which is a really bad idea to do. If it helps them when they're on there, like if they're supine and that's what makes them know how to stop it, that's a cue you can use. I just reiterate, don't stop your urine when you're on the toilet. Then you could possibly start getting urine pocketing in the urethra. You can start seeing people not completely emptying their bladder. When you sit down, your muscles are cued to open and go, so let it be. But yes, you can use that cue.
Dr. Chen, could you explain about the questions that you want to give students from pelvic floor? What parts of the lab is going to be in it?
So the
Or
only
if it's just lecture?
That's really going to be in it is probably the biofeedback stuff, right? So kind of going back to, is the muscle tight? Is the muscle short? What would be the best way to help the patient? So it would be a biofeedback question. I won't put any SI on there because you won't really have SI on your boards. They're not going to put that on there. And if they do, it's going to be far more geared towards an ortho thing than that crossover in pelvic floor that I always see. Let me think what else is on there. Yeah, not much from lab. It'll be mainly from the main lecture.
You have some case study in the lab, but they are coming from the lecture. So that could be included in the exam, right?
Sure. I'll give you an extra 10 questions on top of those kind of case studies.
Okay.
I probably won't make them as wordy with multiple questions below it because I wanted to use that more as like a conversation, like a group conversation. But this is all so different since we're not in the same room.
Okay. I think there is another question that we didn't talk about. For diastasis, would you use those assessments and use them as intervention for restriction found? Then do core strengthening exercises.
I think I talked about it a little bit. So when you assess it, it's just giving you a foundation of where they're at. I would use myofascial release to see if I can reduce it, and then I would work on transversus abdominis only.
Mm-hmm. Oh, students want to have your email. Can I share your email with them?
Yeah, do you want me to type it in now or?
Yeah, you can.
You guys can actually email anytime you want. So like, let's say in 2 years, you're starting to treat patients, not even pelvic floor, but their signs and symptoms don't seem right. You can email me and say, hey, this is what they're presenting with. Should they see a pelvic floor hip specialist?
Thank you for sharing.
Yeah. Any questions? Crazy stories? Anything? It's so different when we're not in the same room.
All right, this is our last session, guys. Any questions or anything that, well, everyone's saying thank you.
Okay, you're all welcome.
I love to hear your crazy stories, though.
I've got some doozies. I'm not going to lie. I've had some very strange individuals with very strange requests, and they ask me things if this is okay, and I don't know where people come up with some of this stuff that they do, but they do it.
So let me do this. If anyone wants to end the meeting, you're allowed to leave. But if people want to stay and hear some funny stories, just stay and hear some crazy stories. How about that?
All right. Some people aren't down for stories. Okay. I had this one woman